Welcome to PUENTE Lab, a podcast where we have conversations around mental health. I'm your host, Dr. Jonathan Martinez, professor in the Department of Psychology at California State University, Northridge. My Puente Research Lab focuses on addressing mental health disparities in care for underserved communities, particularly for Latino families. The goal of our podcast is to create a bridge between science and the community. Today's guest is Dr. Bianca Villalobos, an associate professor in the Department of Psychology at California State University, Northridge. She is the co-director of the SALUD Lab, which is dedicated to increasing access to culturally responsive, evidence-based mental health services for underserved communities. Very proud to call you my colleague at CSUN. I know we have a lot of overlap in some of the work we do, and I was just curious of what led you to down this path to tackle mental health needs in families.
I've more recently kind of put this together for myself because at each stage of my career, I have to re-evaluate, what brought me there and consider what I'm passionate about. And more recently, I've kind of remembered how much I really wanted to be a teacher for so long. Right. And when you're a clinician, a lot of times you are conveying information to clients like a teacher, like you are teaching them skills and things that you've learned. So I've always had that kind of inspiration to convey knowledge to others, to transfer knowledge that I have to other people. And now I can do that with families who are going through mental health problems, but also with students who I can mentor, in research, and students that I can teach in the classes that I provide at CSUN. So right. I feel like I've kind of reconnected with what I've always kind of felt passionate about. When it comes to the cultural lens, trying to think about how culture impacts this help-seeking process, that really came from reconnecting with my own cultural identity in college, right. and taking classes in Chicano art and Chicano English classes and minoring in Spanish. That was me reconnecting with my culture, right. and discovering that I could integrate that with my passion and love for psychology and see that we are very unique, this Latino community, and culture impacts the way that we access mental health services or decide to use them.
These different populations that you work with, whether it's students or the community or clients in a more formal capacity, how do you navigate your role there and how you communicate or give information to these different types of groups?
First and foremost, you learn all the technical jargon of your field, and you have to throw away all of that out the window. And to some extent, you need to teach those things to the students who are studying psychology, but I find that the information gets absorbed much easier when it is broken down and connected to people's life, daily experiences, right? Mm-hmm. And you know this as a professor too, the way that we can connect with our students is by making them aware of the psychological processes that are already happening around them that they aren't aware of. And then finding how they can use this information in their daily lives.
What was your kind of introduction to mental health, and how do you find that it's changed now that you're a scholar in this particular area?
I guess when I think of what my perception was about mental health when I was just first starting to study psychology, all I really could conceptualize or think about was being a therapist and people experiencing things sad, depression and anxiety, and that those were the major problems that I could help somebody with. And it was very limited to being a clinician. And that was the only kind of career option in psychology, right? And so as I've gotten more training and more education, to me, it's about, explaining why people do what they do, why people think the way they think, and how people can gain insight and learn about themselves in order to improve their health and well-being. That person that is the whole and complete person and everything that makes them who they are. Right. And how do we get people to function in their lives, being able to go to work and being able to have relationships with other people or be a good parent if that's what's at stake for them. Right. So I remember getting training and learning about like the local social world of a person being like what's really important, what is of value to them.
Mm-hmm.
And I think we try to find that in each person, in each client that we work with. What is at stake for them?
How do you explain culture to others? Like what is your way of like honing in on like what's important? I know you were saying about the like what's at stake in that local person's world, but what are other ways that you convey the importance of culture and how it impacts like decision making?
I like what you're kind of pointing at is these identities that we all hold, and that they are not strictly limited to race and ethnicity, which is how a lot of people think about culture in the research and also in the community. Like, I'm Latina, or I'm from Puerto Rico, like whatever country of origin, a lot of people tie their identity or their cultural identity to that.
Right.
But it encompasses so much more than that. It is all these different identities that we hold. And I think now we're getting closer to understanding how we hold multiple identities at the same time. And we call that like intersectionality. That word is, floating around there a lot more and is being used more now than it was before. But I think I explained it to people like those things that you hold dear, your beliefs, right? Those values that you want to pass on to your children, let's say if you're a parent. And gender definitely plays a role, I think, in culture as well. Your gender, your identity as let's say, a woman and in a male-dominated career, for example, that brings out that part of your identity maybe stronger than other parts of your identities. So it encompasses all these things. The way they play a role in help seeking, I think it starts off from the problem, like perceiving a problem, to deciding what type of help will help with that problem, to the impact that getting that help will have on the people around you, on your self-esteem, all the way to sometimes whether or not you can actually access that help. So I see that help-seeking process is like broken down into different stages, and culture infuses and impacts every single one of those stages to the end goal. Did I actually go get the help that I needed to get?
Right. I think there is like some confusion that people have when we talk about culture because it might be circumscribed to only racial ethnicity, right? And that's like, oh, that's one type of cultural identity, but it could be about gender. It could be about region. It could be about, growing up in rural versus urban areas. It could be, these different factors that then intersect and interact, which makes everyone's experiences very different. And I think it's something that I'm very mindful of like me being a Latino male and not necessarily placing my values and beliefs and attitudes to another Latino male that might have different intersectionality than myself. And the only way we know that is by asking, right, rather than making assumptions. You that does work in evidence-based practices, how do you find how to package that material to all of these different intersectional groups? Because it's such a broad, working with underserved communities. That's also like my area, but it's like, are there certain areas that you find that you focus on? But how do you also like package this to all the different communities that are in need of help?
There's no way we could have the time to develop and have all of these different packages of treatment available for all these different groups and all the different combinations of identities that a person can hold. And you and I already know how long it takes for that research to happen, and then how long it takes for those treatments to get out into the community, and how long it takes to get the evidence to show that they work and make them common practice. Like, years and years and years and years and years, and we don't have time for all of that. So we almost have to take a step back and think about the smaller types of practices and changes and adaptations we can make to the people sitting in front of us in the moment, right? So we have our standard baseline evidence-based practice and the modules and how they work and the things that we're going to do in therapy. But how do I transfer this information or make sure that it's absorbed by this person and taken in and applied, and they can use it and they see it meaningful, and that help make it more effective. So it's about like asking people questions, doing really good assessment or interviews where we find out information about the people and what values they have, what matters to them most, asking them what identities they hold that they think influence their mental health, and then going from there in terms of, okay, well, I know I'm going to talk about what trauma is with them.
Right.
Let's say, that's something that I'm going to do in this therapy. And I know that this person holds specific types of cultural values, then I can see how that shapes the way they view their trauma or this problem that they're having. How do I make sure I use the same terminology that they're using and provide new information to them and in a way that they will take and absorb and use?
A lot of my earlier work focused on like that formal like specialty mental health care setting where there's like a licensed clinician talking to a client and those conversations can happen. I want to focus on that formal sector a little bit more and then get to more like other places where we might be able to connect with the community and have conversations around mental health. But thinking about that formal sector, what do you see as like the responsibility of the clinician in like that first session when you have a lot of competing demands of like, I need to make sure that they go through the informed consent form and sign this paperwork. And like for a lot of people, it's like you're filling out, like you're like buying a house with all these papers, right? But what do you see as like the main goal of like that first initial session with the family that you're working with?
A connection. It is connection with the client. It's we use this like cultural value called like personalismo to describe like our need and sometimes want to connect with others like in the Latino community. And I was just recently reminded of this where I did a training with social workers and I like got right down into the training. And it was a 2-day training. So the second day of the training, one of the participants before the training got started just asked like, where are you guys from? Like tell me a little bit about yourself. And it reminded me that I did just think of it as like business as usual, like professional, and forgot that I was missing that connection to the people that I was giving this information to, that I was training. And so, we just took a few minutes to talk about, one presenter said, where they were from and where their family was in Mexico. And I told them about myself. And I think it kind of like put everyone kind of at ease and help them become a little bit more engaged once they knew who we were, as people, as normal people. And sometimes as clinicians, we can forget that there's much more to that first session than the information, the content, right, that we're getting. Clients want to feel like they can trust you, that it's a safe environment, and we can do so much of that while we're collecting the information that we need to get. Just by taking some few moments to tell them about ourselves, to ask them questions about their personal lives outside of the context of your mental health problem, right? So I think it's that connection that we really need to focus on sometimes, and we forget about a little bit when we are occupied with information.
Right, because there's like these competing demands, right? Especially when you're like a early clinician, like starting out in your practice. It's like, I need to make sure that I have them sign all this paperwork, but I also need to come up with some type of preliminary diagnosis, and I need to talk about goals and why they're here and their mental health. And I think that comes at odds with building a connection and just sitting there with the client and understand. It's almost like all of the procedural aspects make the experience many times this artificial experience for families that are going there for the first time, and then they might not ever come back, right? It's like you have this one moment with them for this first hour to hopefully engage them in what you're doing. And I noticed that many times when you're working with underserved communities or communities that aren't familiar with mental health, at least for me, there was a lot of explaining the process of what was going on. But then you have like these tight bounds of like, you have a 15-minute session and other things. What is like guidance that you find or recommendations for how to deal with all of those competing demands while still focusing on the relationship? And like you said, personalismo, and making sure that connection is there.
One thing that I've learned recently from like looking at some of the research is that if we take a strength-based approach to that first session versus a problem-focused kind of approach,
Right.
it can change a little bit of our perspective of the client in terms of deciding how like severe their problem is, and how much difficulty they're having in terms of their day-to-day lives and their different roles. We can judge those things a little bit differently if we're taking a problem-focused approach versus a strength-based approach. So I think one tip that we can have for like new clinicians or people seeing clients for the first time is remembering that you want to see this person as a whole person, not just as their problem, but also the things that they're doing really well.
Right.
And when you can highlight those little nuggets of golden like that in that first encounter, and you highlight those things for the person, I think that helps also with that connection. As a client, I would feel like this clinician sees me and they know that I'm trying as hard as I can. They see the things that I am doing well.
Right.
And it's just, and I'm not limited to just being what my problem is to this person. I'm just not another number or client or
Right.
case for them.
Something I hear from clinicians is, how do I talk about culture with this particular family? And, we have certain protocols like the cultural formulation interview, but it becomes like this almost other task of like, oh, I need to do this in the intake session, but then you also want me to complete this thing about culture. Like, how do you integrate the two of like these to then have a good picture of how culture influences that person's mental health and their decisions?
In like a practical sense, I've supervised students doing clinical work for the first time, and I do see them do some of the things that you mentioned, like hyper focus on writing everything down
Right.
that the client is saying.
Yeah.
And I've got to get every single word. And I lose connection with the person when I don't even have direct eye contact anymore. I'm just looking at my piece of paper and making sure I get all the words. So if you are doing a really good job of like listening and connecting, you'll remember those things that are most important to the person, right? So if you catch those things, I think like the CFI is the cultural formulation interview is a really good tool. And some of the advice I've given is like that you can take pieces of it, those pieces that you think are the most relevant and important, and infuse those into your current practices. Like, what are you already doing? Can you just make space for some of those additional questions so that you don't have to change your whole routine, so that it's not a burden that you have to spend an additional 30 minutes or an hour to ask all these other questions? And the really nice thing about the CFI is that there's all these other modules, as you're aware of, like some that are about religion and some that are for older populations and their specific and unique experiences. So we can go in and tailor our own interviews and make them a lot more sensitive to the person's culture, what's at stake, what values they have.
And like with the cultural formulation interview, for example, there's a question of like, how do other family or friends think about some of these issues? And to me, like that's so important to ask, and clinicians probably ask that in some way. So I like the idea of like positioning with like, it's not like this protocol that you have to start from start to finish, but how do you integrate some of those questions into what you're already asking so that you have a good understanding of some of these cultural factors that influence, rather than thinking, oh, I did an intake and I asked these questions, now I need to figure out also how culture, it's like that at least for I think the work that we do, like that's part of it. It's like you can't remove the cultural lens from how they view their mental health and what's going on in their world.
Absolutely. You like you said, you're already probably getting at these cultural aspects about your client, and you might be unaware of it, but these are pieces of information that are going to be so helpful and essential later on in the other sessions that we're going to have with this person. And they aren't just checkbox questions. Okay, I need to ask this for the sake of asking it, and then I can put it away to the side and it's not going to be relevant anymore. it's going to impact their decision to come back and see you again
Right.
the next time they see you. Along with like culture, we have things like stigma that get in the way. And I think, if you're not getting at culture, you're probably going to miss things that are stigmatizing to the person,
Right.
that their family might find stigmatizing. And family sometimes can be a really big influence on a person's decision to seek any type of help, not just professional services.
Right. But kind of like taking a step back, where do those opportunities happen? Right? Because you think of like formal care, it's like, oh, well, I'm there, I'm in the room with them, I have these opportunities to give information. Where do these opportunities happen outside of like a formal care setting?
If you're conceptualizing formal as like traditional mental health,
Yes.
sitting in front of a clinician in a clinic for mental health problems, then we are very limited in who we can reach, right? So we've got other ways of finding people where they are, and that includes going into primary care, where people are already accessing services for their general health, and then where you find people talking about mental health problems with their primary care providers.
Right.
They're already doing that. And then we've got school-based types of services, because that's where the kids are, right? That makes them a lot easier to reach and to reach their families. You've got things like home-based care. I've experienced with that, where I would go to people's homes and provide trauma treatment and travel up to 2 hours to try to get to these people, because they
Right.
were not going to be able to come to a clinic 2 hours away. And then you have things like telepsychology. That kind of mimics a little bit more of that traditional kind of service, but takes away some of the stigma of going to a mental health clinic and people being aware of you accessing those services. So we've had to become very creative about the ways that we seek people, because sitting in your office and waiting for them to come to you is unfortunately not going to work for the majority of people.
I want to focus on primary care a
Sure.
bit, because like we know people go to their primary care doctors, and like you said, many times they are addressing mental health issues there. Things are very siloed. It's like you think of like primary care and then like mental health care is separate. So how can primary care settings better integrate mental health, and is it a system where primary care then refers to mental health, or is it something more where there's like a team-based approach of different types of service providers at these primary care settings?
So there's different models out there that have been developed to show how this can be done, how the integration can happen. And some models are less integrated than others. And so in a really fully integrated model, you have psychologists or social workers. Any mental health professional is working side by side with the PCP. The PCP is managing their patient care, and the psychologist or the social worker or mental health provider is a consultant. And in a really good integrated setting, you have the mental health provider seeing patients in the primary care setting, in the same patient rooms that they are seeing their PCPs in.
Right.
And it's seamless. There's a warm handoff where the primary care physician is quite literally placing their trust into this other person and inviting the patient to do the same with this behavioral health consultant. So there's one difference right there. We're not calling them psychologists.
Behavioral health consultant.
Behavioral health consultant.
Right.
It again refocuses on like the integration between the mind and the body, and it's not you're not going to see a psychiatrist or you're not going to see a psychologist. It's a behavioral health consultant. So there's lots of ways that integration of primary care can try to take away some of the stigma of accessing mental health services. But you're in the same waiting room that you would normally be in for a PCP. You're familiar with the same interpreters. If you use an interpreter, they're also interpreting. They're using the same medical records and charts as the PCPs, and you know that your behavioral health consultant is talking directly with your PCP about your care, and they're coordinating it for you. They're making sure that all the bases are covered.
And that sounds like fantastic, like an ideal scenario
Sure.
of like coordinated care. And like sometimes I wonder, like, does primary care want that?
Oh my
Do
goodness.
MDs want that? Do they want behavioral consultants there? Will they feel like it's like encroaching on their area? But like to me, it's like, well, where are people getting help? And we know that, our communities, Latinx communities many times go to emergency room settings because health wise they feel like, oh, my heart's racing, it must be a heart attack, or I'm feeling short of breath, or I'm very tense, and it's like a health condition, right?
Mm-hmm.
And then in those conversations you find out it could be anxiety, it could be a panic attack, could be panic disorder. And like you said, that warm handoff would be perfect to then introduce a behavioral consultant. But then I also wonder whether like the systems want that, or whether like the siloed piece is like almost territorial, so to speak, of like, no, this
Sure.
is, you stay in your lane, like you.
There's a lot of that
Right?
that happens. And you are very much right that we as psychologists have to be like salespeople to some extent and make that pitch of like, why? Why does it make sense, especially from this public health model? Why does it make sense to integrate psychological services into primary care?
Mm-hmm.
So there is a lot of work that
Right.
actually has to be done from the administrative level down to the PCPs and the staff,
Right.
and making sure that referrals are getting made. And so it's based off of making sure that that people see the connection between us addressing the psychological problems, helping with the physical problems this person is having. Like if we
Right.
directly address these things, we will see and make a difference in this other aspect of their health.
Mm-hmm.
And so if we can make those connections, not just to the PCPs, but to the administrators that can help support the process of making those referrals, and to provide psychologists with the space, and to ensure that the integration is happening, then we can be more effective. But you do have to drive home that point with a lot
Right.
of people and make sure they see that connection.
When I think of other settings like schools or churches, I wonder who are the people to integrate that are the mental health folks, and what are their titles, which I always wonder in these other settings. Like, what is your view on it?
Oh gosh, I think that especially in other countries outside of the U.S., there's more research being done on how do we train lay people in the community? How do we train teachers? How do we train religious leaders to be better equipped to handle mental health problems of
right.
the people they're interacting with?
Right.
And I feel like we're getting closer to that in the U.S., like training maybe promotoras or community health workers to feel more equipped to make referrals, to address mental health problems in the community, because they're the boots on the ground. They know their community. They know these people and the struggles and the problems that they're facing and the challenges that they encounter. They know them best.
Right.
So we almost have to think of including other people, key stakeholders, people
Right.
that really hold a lot of value to our clients, and engaging them and training them, better equipping them so that they can manage problems of the people that they're interacting with, in the day-to-day.
You mentioned earlier about telehealth, and I wanted to talk a little bit
Sure.
more about that, of like, because we had some conversations in like this in-person formal setting, one-on-one. Where do you see the field of telehealth going, and how can that better address certain barriers to care?
So telehealth is not necessarily something that's new. It's happened since the 50s. It's been around for a long time. And I was actually engaging in telehealth services. I was providing trauma treatment via telehealth before the pandemic. Once the pandemic hit, it just made it more clear and evident that we need to find, again, creative ways to reach people when they cannot be physically present with us. And so many clinicians have now adopted telehealth practices that they provide both types of services now. And telehealth didn't really go away once people were able to see each other in person after the pandemic. So it's really now another option that is permeating, the the field of mental health. Like you can get care that is effective and that works.
Right.
And still do it from the comfort of your home or from a school or from primary care. You can do telehealth in those settings as well and enhance the reach of the services. So I just think there's more acceptance of it now from clinicians who were maybe hesitant to use it before because they didn't think that it would be as effective as in person.
Right.
Now we know the research shows it is equally as effective as in-person treatment.
Especially like when you think of like all of these logistical barriers to people getting help and like all of the obstacles they have to get to just be able to see you in like a certain setting in the physical location, that, you know, telehealth makes it much more accessible. So kind of reflecting on our talk, I'm just seeing like this theme of, you know, what care means and like all of the creative ways in which people could get their mental health needs addressed. And yes, for some people, it's in a formal, physical, in-person setting. And then there's like other settings where people could get help and get complementary care and self-care. Also, it's, I think, aspect of thinking of telehealth as something that could also create more accessibility and improve people's ability to get help. What's a take-home message that you see from our conversation?
Absolutely, that we have to reach people where they already are. And I love that the message of like being creative about how to do that. We can, as clinicians, provide more options to people. That's how we're going to reach more people. When it comes to people in the community thinking about mental health, I think them knowing that all these other options are available to them, it can empower them, right? Because it gives them choice. And sometimes when we have mental health problems and we need help, we feel like our choices are limited. And there are a lot of barriers that prevent us from accessing them. But the more choice I have, the more power I have in making a decision that's right for me. Right. So I think that would be a really good take-home message for people in the community, that you have more options available to you now, and you can choose what makes sense for you.
Well, thank you, Bianca, for having this conversation. Thank you for all the work you're doing in this area. I'm very proud to call you my colleague at CSUN.
Thank you, John.
Thank you for joining us today. To access more mental health content and resources, please go to puentelab.com. Until next time.